welcome. I'm Ali Jaffe. I'm one of the co-founders of Tank, and today's discussion is going to be extremely exciting because we're talking all things psychedelics with Dr. Chloe Sakal, who's a psychiatrist. So, Chloe, start off by telling us a little bit about yourself and what drew you to the world of psychiatry.
Oh, thank you for having me, first of all. I'm Chloe. I'm a psychiatrist. I work in Bristol. And at the moment, I'm actually not doing clinical work. I'm working with a non-profit organisation called Drug Science that was founded by Professor David Nutt. And we're a scientific body that provide non-biased evidence about drugs. It was formed to combat the laws about drugs which aren't based on science. So I'm sure, as everyone knows, alcohol is legal, even though it's the most dangerous drug there is, which doesn't really make sense from a scientific or clinical perspective. I'm working with them to bring cannabis and psychedelics in line with our current. And I've also done some work in the past on trials with MDMA assisted psychotherapy and psilocybin assisted psychotherapy as well. So you asked me why I was drawn to the world of psychedelics.
Take us back way back then.
I think it's just fascinating. I think in psychiatry we have very few tools to use. So we have listening, which is probably the most powerful tool we have of all, but we have very few medications. It's quite different to a lot of the other medical specialties. We essentially have antidepressants and antipsychotics, and that's it. So you've got two classes of medication. And to be honest, they don't work that well. They don't work particularly well. That's not to say that they don't work at all. They do work for some people and they can really help. But there are a lot of people that they just don't do anything for. And mental illness is really prevalent these days. And if you're suffering with things like depression, anxiety, it's really debilitating. It's a really difficult thing to suffer with. So I wanted to look into something completely different and think about different and new ways to treat mental illness. That kind of led me to the door of MDMA and psilocybin assisted therapy. And there's lots of clinical trials going on with them in the UK at the moment. And they're showing really good results, especially psilocybin. So psilocybin, which is the ingredient in magic mushrooms, if anyone doesn't know, is being used to treat depression. And I really like that it's not a maintenance medication. So with most antidepressants, you have to take them every single day. And often people can end up on them for a long time and have difficulty coming off because then they suffer with withdrawal effects. But with psilocybin, you can have just one dose and that can lift your depression for up to 2 years.
Wow.
So
that's absolutely extraordinary.
Yeah, I think it's great.
It's not legal, which we're going to delve into.
Yeah.
So let's rewind a little bit and tell our audience a bit about what the term psychedelics actually means, when it came about, and let's just get into, from the onset, all the social, economic and health issues that have been tied up with them.
So I think that the term psychedelic actually, it literally translates as mind manifesting, I think. So that's based on the idea that it literally manifests what's in your subconscious. So a lot of us suppress what's going on in our subconscious, which is usually what happens in therapy. You try to dig down to what's really going on. But psychedelics literally manifest what's going on. So the world will turn into what's going on deep in your subconscious. So that's what the term means. I think it's other drugs like ketamine and MDMA is loosely involved in that category, but psychedelics, the classic psychedelics, are things like magic mushrooms, LSD, ayahuasca, mescaline. So they're the ones that have the hallucinogenic properties as well. And what was the other part of your question? Sorry, Ali.
So let's talk about all the documented historical issues around and why it's been given a somewhat bad rep and the kind of stigma that comes with it.
Yeah, I guess as everyone probably knows, in this country, the only drug that is legal so we've got nicotine, caffeine and alcohol that are all legal. Nicotine and alcohol are both pretty dangerous, really. They're both quite damaging drugs, which begs the question of why psychedelics and cannabis are illegal. I don't know, Ali, if you've ever seen that graph that Professor David Nutt made that shows the dangers of drugs. So he made a chart of the dangers of each drug, and alcohol was right at the top, the most dangerous drug to both the individual and society. And psilocybin, magic mushrooms, was right at the bottom. It's incredibly safe, really safe. So cannabis, I can tell you a bit about the history of cannabis. That was legalized back in the 70s, I think. And that was a political move in the US because cannabis was often smoked by Mexicans. They wanted to find a reason to demonize Mexicans to stop them coming over the borders.
Right.
So that's where they came up with the name marijuana, because it sounds Mexican. And it was legalized as a way to incite racial hatred. So it was nothing to do with the science of cannabis.
Mm-hmm.
And there was a sort of similar story with MDMA, that it wasn't based on science. It was a political move. I'm aware that a lot of the campaigns that have been anti-MDMA, I don't know if you remember this, the Leah Betts scandal. I think this came out when I was maybe about 15. It was a young girl who died from MDMA.
I think I've been told about it, but I don't know how around I was.
Yeah, so some time ago. So she was a teenager who took a pill, right, an ecstasy pill, and died, and it ended up on the front page of all the tabloids. Mm-hmm. And that campaign was actually funded by the alcohol industry.
There we go.
But fascinating, because if MDMA carried on being used, it would decrease the profits that the alcohol industry gets, because often when people take ecstasy, they don't drink as much. So once again, you had one death from MDMA, there's hardly ever any deaths. There's been like 20 deaths over the past 10 years from MDMA compared to the thousands. So it's not based in science again.
Yeah. And I remember the reason why I wanted to get you on was I first heard about your work when I went to Dr. Ben Sess's talk in Bristol around the research project he was working on with MA and its clinical utility for alcohol misuse disorder. Yeah. And I remember asking him one of the questions, why do we hear so much about the health hazards of MDMA? And he said, you've got to think about the context in which MDMA is taken. People are partying, dehydrated, sweating in huge groups for sometimes just under 24 hours. They're not having sleep. We know how important sleep is for mental health, physical health, immune system, etc. So you have to take apart all the different social and life context of when that drug is taken. And so I guess that's what happens with the media as well. So it's really fascinating. And yeah, like I said, that talk for me was so eye-opening, which is why I wanted to get you on.
Cool.
So before we dive into that research project around MDMA and alcohol misuse, let's just set the scene a bit more. So you've mentioned science, which is so important because so much of this research has obviously got barriers due to the political and legal issues. Mm-hmm. So tell us about the organisation Drug Science that you're working for at the moment and the aims of the work.
So Drug Science was founded by Professor David Nutt about 10 years ago. And this was after he was fired as the government advisor on drugs, because he said that he said that ecstasy was less dangerous than riding a horse. And he said that in the media, which is actually true. It is. Taking an ecstasy tablet, you're less likely to die than you are from horse riding. So he was absolutely right. But the government was so outraged that he said it. He was fired. So he founded this organization in the way of setting something up that's independent from political influence to provide actual evidence-based scientific information on recreational drugs, because so much of it is influenced by politics and profit and things that it shouldn't be, because really it should be based in science and it should be based on proper clinical evidence.
Absolutely.
So we produce scientific publications about recreational drugs.
Yeah, and that's exactly what we need. Something credible that's a platform and not tied to any sort of political or legal agendas. So let's delve into the psychiatry world. So how many years have you been working on drug science research, would you say?
So I actually haven't been doing it probably about 2 or 3 years now.
And so how would you say your colleagues have taken it, and how would you say that would you say it has more stigma around it than other areas?
I lost you there for a moment. Sorry, say that last bit again.
I said, so let's talk about it in the psychiatry sense and working with your colleagues. Would you say that, so you've been working in it for the last 2 or 3 years. My first question is, I'm just trying to articulate it. I'm trying to say, so do you think it is quite a controversial area that there's more of a willingness to go into it when you're a bit more senior, where you've had that clinical experience rather than diving into it as a junior, because more around psychiatry and the fact that, like you say, there is not less utility, but antidepressants and the other medications you described are having limitations at the moment with their effectivity, so you know, oh, I need to look elsewhere. How do you feel it is as someone interested going into the world of psychedelics, for instance? What advice would you give, and how do you feel you've been met by your colleagues?
You know what? I think it's advice for anyone who wants to go into it. I think it's absolutely fine now. I think Ben Sessa said 15 years ago when he was interested in it, he was really stigmatized for it. But I live in Bristol, which is probably quite a liberal place to work.
Absolutely.
Yeah, and I haven't.
Medical school I go to, very liberal.
Yeah, I haven't had any negative comments from any of my colleagues.
Wow.
They're all really supportive, even about, because I'm working with medical cannabis at the moment mainly. And a lot of my colleagues are happy to, so we've started prescribing it. So cannabis is now a legal medicine to prescribe for psychiatric disorders.
Oh wow! And so which ones in particular?
Which conditions? Yes, we're prescribing it for chronic pain and anxiety and insomnia. So PTSD, anxiety, insomnia, and you can now get that on prescriptions. In fact, I think just last week we got the first batch of actual cannabis to patients. Wow. After much battle with the Home Office to get it imported into the country.
Where did it come from?
I think it came from South America. It's grown out in South America, I think.
That's so interesting. I had absolutely no idea that psychiatrists are at liberty now to prescribe.
Yeah, there's a cannabis farm in Devon. There's one in England.
Epic. Must visit.
Amazing.
Going back in time a bit to why it was stigmatized, the work of psychedelic research within psychiatry. I remember last year when I was doing my BSc in medical humanities, we learned a lot about the work of the psychiatrist R.D. Laing and how he was at the forefront of the anti-psychiatry movement, which was a movement that came about in the 70s to eradicate the mistreatment of patients with mental illness and how they'd been mistreated in asylums. And so he wanted to come with a compassionate approach and create his kind of own rehab centre in a way for those with mental illness, and to really try and take a creative approach. And in doing that, he became known for giving his patients LSD to elicit that kind of creative therapeutic outlet of their mental illness. And then obviously he had some good results here and there with helping people, but what eventually did happen was people had LSD, had some accidents, jumped off balconies and whatnot, many tragedies, many deaths that not ideal at all when you're a doctor. And so it got that bad name from it. So that's why I wanted to ask you initially, like how the stigma is today in the 21st century with fellow psychiatrist colleagues. So what could you elaborate a bit on the history of psychedelics?
Yeah, I think there's quite a lot of propaganda out there about psychedelics. I mean, it's not, there's that whole take LSD and jump off a building narrative, but I don't know how many times that's actually happened. And I suppose, like you were saying, Ali, it's all about the context, the set and setting. When you're taking, so I don't think there's actually much research going on to LSD at the moment, but psilocybin, which has very similar effects, but just acting, when it's taken in a clinical setting, those sorts of risks just aren't there. You're in a clinical facility, you have doctors and nurses with you, that the risk of a patient that they wouldn't be able to leave, that there's no way they would be able to harm themselves. So that sort of risk is completely negated. I've done quite a lot of work at festivals as well. So I do trip sitting at festivals. If people have taken, it's so much fun.
I saw that in your bio and I was like, wow.
Yeah, it's so much fun. Great way to get free tickets to festivals as well. Just even at festivals, I've never had to have someone sedated or sectioned. Even when people have taken, so at festivals, when people have taken too much of a psychedelic, we keep them safe until the psychedelic's worn off. And actually they are always fine. And I've never had to, as of yet, I've never had to do a section someone or sedate them. You just look after them and they come through it, and often they feel great at the end of it. So I think there's a lot of misinformation and propaganda that has been out in the media I think it's just there to frighten people, really. I think there's a lot of fear from regulatory bodies and things because people are afraid of things they don't understand. And the psychedelic experience is quite out there. It is something that is quite unusual and doesn't necessarily fit with everyone's understanding of reality. And I think that often brings around a lot of anxiety when people don't fully understand it.
Absolutely.
Yeah.
And so, you know, all the misinformation in the media and the fact that it actually is legally bound, that there are schedules that limit what drugs can be used medically. Can you tell us a little bit about the legal aspect of things and the kind of hoops you have to jump through and the bureaucracy when you are registering to do a research project?
Yeah, it's really annoying. So at the moment, psychedelics sit in what we call Schedule 1. So that means there's no, it's illegal and there's no medical use. Yeah. Psilocybin's just about to be descheduled though. It was in the Daily Mail on Monday.
That's so exciting.
That was Drug Science's work. Yeah, so we've been pushing for that. So we have politicians that sit on the Drug Science Board, and it's going to be descheduled. Because it's interesting because, so we just need it to go into Schedule 2, which means it's illegal, but it has medical use and you can research it without having to pay a lot of money for a home office license. And at the moment in Schedule 2 sits heroin and ketamine. Right. They sit in Schedule 2, even though they're more, heroin's much more dangerous than psilocybin. So it doesn't really make sense.
So why do you think that, was it random? Why do you think that certain drugs have had a schedule assigned to them that doesn't really make scientific sense when you're looking at the actual hazards associated?
If I had to be really skeptical, I would say it's to do with pharma profit and who is, which politicians have shares in which pharma companies.
There we go.
Very skeptical, but it does happen, unfortunately. It does happen.
Yeah. And so because of all these legal issues, that is why we saw such a halt in the research and the kind of potential of clinical utility of drugs that we've discussed so far, because this is no new concept of the power of psychedelics and mental illness therapeutics. We saw it in the 70s, and then with the rise of the Misuse of Drugs Act and all the legal binding, all of this went out the window. So would you say now, with the work that you're doing, we're in somewhat of a kind of psychedelic renaissance with so much research and the laws and schedules slightly shifting?
Yeah, I mean, I hope so. It feels like it's going in the right direction. I had a meeting today. I can't see that.
You've gone a little bit quieter.
Hello? Hello. Yeah, I think I covered my mic by accident. I think I can't really see how it's going to be stopped now. So we've got cannabis past the line, and now doctors can prescribe it and it can be transported into the country, and patients can now get actual cannabis flower the next day if their doctor prescribes it. So that's been done. And our Drug Science Board work very closely with politicians, and so far it's being supported. So it feels like, unless something catastrophic happens, that we just need to finish the clinical trials, and then they'll be licensed for use.
So let's dive in. Tell us about the clinical trials. Tell us about the work that you're doing with MDMA and alcohol misuse disorder.
Yeah, it's a shame that there's this pandemic, because a lot of the trials have had to
need in person.
Yeah, so the MDMA study, that's finished now, but that was using MDMA assisted therapy. So patients took a pretty good dose of MDMA, so the same amount that you'd probably find in a pill. So it's about, I think it was 125 milligrams. That is enough to get you high. And then they sit with the therapist and they talk about their trauma. So I think the rationale is that often underpinning alcoholism is trauma. So when people are traumatized, it can be so painful to think about, and you can end up very anxious a lot of the time. You self-medicate with alcohol. That's the sort of rationale for why it would work. You give someone MDMA and that shuts down the amygdala, which is our fear, the part of our brain that regulates anxiety and fear. And then it enables the person to talk about whatever their trauma was. So say it was something like rape or combat PTSD. Often patients can struggle to talk about it because it's just so traumatic, understandably. But if they take MDMA, they no longer feel anxious or afraid, so they can talk about it, process it, and then hopefully they won't need alcohol to self-medicate with going forward.
Wow.
So it seemed that the results were quite good from the study. There were, I think, maybe one person relapsed, but considering that alcoholism is incredibly difficult to treat, I think it's about an 80% relapse rate. Out of how many participants? I think out of the 14 participants, only one's relapsed. That's pretty good results.
Absolutely.
Yeah.
And in terms of people's tolerance, like the tolerability of the drug, how did everyone respond? Were there any sort of adverse effects, or just,
Yeah.
is it different for every person? Were people's responses
Yeah.
different?
Yeah, it was interesting actually. It's overall, MDMA is one of the better tolerated drugs. So often people find psychedelics quite challenging. So high doses of psychedelics can be really quite mind blowing and can be
It can
frightening.
like cause like nausea as well sometimes.
Yeah, but even the sort of, what's the word? The kind of cognitive effects of psychedelics
Right.
can be really, they can be very frightening. You're seeing deep into your subconscious, and if there's trauma there, it can be quite overwhelming. But MDMA is pretty much universally pleasurable. Pretty much everyone finds it pleasurable. I think a few of the participants felt a bit nauseous coming up. I don't think anyone actually threw up, but there was one participant who unfortunately had a bit of a panic attack when sometimes when MDMA starts to hit, you can feel quite panicky and anxious as it's kicking in, but then it tends to balance out again. And one participant had a difficult time with that. But overall, it was very well tolerated and people really enjoyed it.
And so you mentioned you only had one participant that relapsed. How many sessions were required with each participant to really get them to a stage where they can be left in the community to their own devices and not have to have so much follow-up?
So it was an 8-week course. So the patient had therapy every week for 8 weeks. And on week 2 and 5, that was MDMA assisted. Weeks 2 and 5, they had the drug. The other weeks were just normal therapy sessions. Yeah, and then I think they pretty much all of them carried on with their normal community kind of rehab groups. I think some of them attended AA and things like that. So they still continued with their normal interventions.
And what was the rationale for when you include the MDMA assistance?
What do you mean by that, Ali?
When? So you said on the 4th.
Oh, 2 and 5th. Oh,
yeah, when you do it within the 8-week course.
So you always, I think it's the same across the board with any kind of psychedelic assisted therapy. So you have the first session to explain to the patient what's going to happen and what to expect, just to set and to build up a rapport with the therapist as well. So I think most of the participants in this experiment had never taken MDMA, which is quite interesting for Bristol.
Very much, considering Bristol's got the name Bristol Bladder for their tech use.
Ketamine, yeah.
So I'm shocked at that, but okay.
So you always have the first session just to meet the therapist and explain what it's going to feel like, what's going to happen on the day. I don't know why 8 weeks, if I'm completely honest. I think in America, where they first developed the course, I think it's actually longer. I think the American version is like 12 weeks.
Right.
But because we're trying to head towards NHS, we have to make it cost effective.
And so tell our audience about the cost, because I remember Ben Sessa saying that 125 milligrams, it was the most extraordinary cost compared to street recreational costs.
Yeah.
So I'm just grabbing my charger, just tell everyone.
That's good. Yeah. So for a gram of medical grade MDMA, so a gram of MDMA on the street costs around £20 to £30 these days. For a gram of medical grade MDMA, it cost the study £9,000.
Wow.
£9,000. The best MDMA we've ever seen, probably.
It's truly shocking. And now that the project's completed, where's it going? What's next in terms of developing it further?
Yes, so there's some other, we're not doing it in Bristol, but there's a site in Cardiff and I think maybe one in London maybe, that are doing phase 3. So when you bring a drug to market, you have to go through phase 1, phase 2, phase 3. So phase 1's healthy volunteers, phase 2 is with unhealthy volunteers, with patients, and then phase 3 is a randomized controlled trial.
Right.
So MDMA assisted therapy is now in the phase 3. I know Cardiff are doing one of the studies. So once they get through phase 3, it'll be licensed, and that means you can use it in practice. So psychiatrists will be able to prescribe it.
Wow, that's extraordinary. And in terms of putting this in context with the rest of the world, you've mentioned the States. So who's ahead of the game in terms of mental health research and psychedelics? What's happening across the waters?
I think there is one, I think it's Switzerland. Switzerland, I know, yeah, I think it's Switzerland. In Switzerland, there is a psychiatrist who has a compassionate use license, who is actually already giving LSD therapy legally. because he's got a license to do it ahead of licensing, which is interesting because he managed to prove it was that effective.
Wow.
And then obviously in Holland, there are lots of retreats because psilocybin is legal there.
Fine.
So you can actually get psilocybin-assisted therapy in Holland if you wanted to get it legally.
Sure.
Yeah.
And so moving away from MDMA, can you tell us a bit more about the usage of other illegal drugs and their clinical utility? For instance, ketamine and depression studies, and you mentioned at the start psilocybin and was it depression?
Yeah.
So yeah, just tell us a little bit about them.
Yes, so ketamine is already licensed in the UK. You can already give ketamine for depression if you wanted to. I can't remember if it actually went through, but there's now an S-ketamine nasal spray, which I think is licensed for depression now, which I know blew my mind. So it's just a nasal spray. There's a clinic in Oxford actually that does ketamine infusions for depression, which I went to recently. If you have depression, you can go in and be infused with ketamine. And
pharmacologically, how does that work? What is
That's a good question.
Yeah.
I think it's
my mind a bit that it's a pain that I know about it in the context of pediatrics used as a painkiller in the emergency department. I just can't understand how it being infused can.
Yeah, I have to say I don't know that much about ketamine, but I think I think it has anti-inflammatory properties, so it has a neurogenesis, so it causes neuron regrowth and has anti-inflammatory properties. So a lot of depression is thought to be caused by long-term stress and inflammation. So then your neurons die off, and there's just lots of inflammation in your brain. So anything which is anti-inflammatory and causes new growth can have antidepressant properties.
Sure. Yeah. That's okay. We can move on swiftly, but I'm sure it's like more than anyone else on here, so it's all good. And then psilocybin, tell us about that and how it works as an antidepressant.
So that's a bit different. Psilocybin's quite interesting. So it causes increase in neuroplasticity. So the theory around depression with psilocybin is that as we go through our lives, we can become more and more rigid in our narratives about ourselves and the world. So if you ever speak to somebody with depression, they can have quite rigid ideas about things, like I am useless, I am not lovable.
And that rumination.
Yeah, and they can go, you can, if you've ever spoken to somebody with depression, it can be really hard to get them out of that.
Sure.
They'll say, oh, everyone hates me, my family don't care, the world's a horrible place. And you can introduce alternative narratives, but they won't take them on. If you say, have you thought about maybe your family do love you? They can say, no, they don't love me.
So their readiness for change is just completely inhibited. Okay.
Yeah. So the pathways are so well defined in their brain, these neural pathways. It's very hard to get them to see things from a different perspective. So psilocybin creates more connectivity in the brain. So it leads to a more plastic neural pathways. So you can actually introduce new ideas and people are able to adopt them. Which is why often people in Silicon Valley use psychedelics, because it brings about a new way of thinking.
That was my next question. Yeah. Because I'm very interested in the world of microdosing and how professionals, especially like in the tech or innovative startup world, are microdosing on psychedelics to improve efficiency, productivity, creativity within their work approach. So yeah, tell us a bit about that.
Yeah, there hasn't been much research on microdosing, interestingly, because it's so hard to do, because you'd have to get the person to come into the lab every day to pick up the microdose because of the scheduling. But a lot of anecdotal reports of people using it to, apparently it's good for creativity. And I suppose I can understand why that would be, because of the kind of flexibility it creates in your brain. Yeah, I've heard a lot of people say that it helps them to think about things in a new way.
And I've also read about psilocybin's use when it actually comes to drug dependency, which I found the most counterintuitive thing when I first read it, because I was like, ooh, using a drug to treat another drug problem. But then with what you've just mentioned, that completely makes sense, because I guess with addiction, and as I've learned in my psychiatry placements, you become so entrenched, those kind of rigid behaviors, and to break that cycle is so challenging. So of course you're going to need some sort of intervention to actually break that cycle. And if as you say with psilocybin, if it's actually creating neuroplasticity and allowing those rigid ideas to really be broken, then I think it could be so fascinating.
Yeah, no, it is interesting. I know there's a lot of research about ibogaine use for opiate dependence. Ibogaine's another type of psychedelic. It comes from a tree, it's bark of a tree. And that apparently is very successful in treating opiate dependence. I think what's interesting about psychedelics is they are really not addictive. And I think a lot of the time people will say drugs aren't addictive when they actually are, like benzodiazepines. But you just don't see compulsive use of psychedelics because it can be quite, it's not necessarily a pleasurable, easy experience. At high doses, it can be quite challenging. So you just don't see that kind of addictive use. Yeah, so it breaks rigid thinking and allows people to...
Are trials happening in the UK when it comes to addiction and psilocybin? Are there actual trials? Is it in use yet with drug dependency treatment? Do we know?
So there is a psilocybin for opiate dependence study being set up, but it's not running yet. But that's in the pipeline. Yeah, okay. That'd be quite interesting.
Yeah. That's fascinating. And what are you working on at the moment? So you mentioned that you're taking, did you say, a year out from your clinical psychiatry to work with Drug Science, the organisation that you're aligned with. So what are you up to?
So I have been creating a medical cannabis registry. So basically any patient that is prescribed medical cannabis in the UK, I'm going to pull their data. So I've created this sort of registry software where doctors and patients can enter in their data to monitor how they're responding to medical cannabis. And then we can pull the data and then analyze it and present it to the regulatory bodies, so NICE and the NHS, and hopefully because at the moment to get medical cannabis, you have to go to a private doctor. It's not available on the NHS for most conditions. It's available for, I think, nausea and MS-related spasticity. But for mental health problems, you have to go private. So we're going to pull all the data from the private clinics and present it to the NHS and see if they will adopt it. Wow. So that's the idea, trying to push medical cannabis into the NHS.
And what's the timeline, do you reckon, on that? When do you think, granted that they say yes, when do you actually think we could see it being part of routine management?
Yeah, so actually I had a meeting with the NHS, I think it was last week, and they're very supportive of what we're doing, and they want to adopt our sort of data collection system into the NHS. So I imagine it will happen quite soon. They were supportive of it. Once again, I haven't really come across much backlash. I think attitudes towards cannabis have changed as well. Even the Daily Mail was supportive of our project.
Why do you think that is? What this shift that we've seen? Because there's been a lot of compassion with its use in childhood epilepsy, and I think that was a huge case. I forget the name of
Alfie Dingley and
absolutely a hugely compassionate case, because once again the only thing standing in the way is the legal battle of actually obtaining it. That is the thing that's going to help a child with their health and well-being. Why else do you think we're seeing this shift with medical cannabis?
I suspect there might be something to do with the opiate crisis at the moment. So one of the big things that we're looking at is using cannabis as an alternative to opiates for pain relief. Wow. Because there's such a massive opiate crisis in the US, they've really pushed cannabis through. So now it's legal in quite a lot of places in the US, and in Canada it's legal. And there's a lot of evidence that patients are able to come off opiates, use cannabis instead, but actually people function much better on cannabis. Because opiates, they're such strong drugs that people are often really cognitively knocked off with opiates, and they feel sick and sleepy, that they can't also go to work. Whereas what they're finding with medical cannabis is that it controls the pain and the anxiety, but people can still function. So the government are very keen to fund that because people can get back to work.
Sure.
So that's my theory.
Very interesting one. It's just very fascinating to me the replacement of one drug with another. And what I find interesting, and we've touched on this already, is how you can use a psychedelic, or how you've just mentioned another drug, a class B one, to replace something or aid something within the addiction cycle. And so when we were talking about psilocybin and it helping with drug dependence and addiction, how do you think that psychedelic drugs could actually help in an overall way with behavioural change and addiction? So if we're talking about smoking, we're talking about binge eating disorder and perhaps even obesity, and just trying to change behaviors around, say, food. I'm mentioning food because we're NutriTank, but also smoking and other issues.
It's a really good question. I'm just thinking that one through.
If the therapist is in the room with someone and their neurons are completely plastic and they're able to engage, because all the issues with motivational interviewing and everything is where that patient is in that cycle of change. Are they ready to actually meet with you and take on that kind of partnership in moving them forward away into a more kind of healthy lifestyle? It's all about readiness. And I'm wondering if it's psychedelics that push someone straight away into, they just make it happen faster.
Yeah, I suppose if, I guess a lot of habits are once again about rigidity. So once you get into kind of bad habits with bad diet or smoking, it's quite a rigid, sort of the same rigid pathways of firing again and again. And I think something like a psychedelic, it's just so mind-blowing. It presents a patient with so many alternative ways of being. I say that, so I was a participant in one of our studies. So I was a participant in a DMT study. So DMT is a very strong psychedelic.
It's quite exciting that you got to be a participant.
In an MRI scanner. It was terrifying. So I was injected with a high dose of DMT, and it's just so mind-blowing. It is just such a different experience, like nothing else, that it just opens up all these avenues for thinking about things differently. Even if you've smoked every day for your life and you think, I could never do anything differently, I couldn't possibly go out smoking, having this type of experience shows you that anything's possible. It's very hard to explain if you've never experienced a psychedelic. It's very outside of what we would consider normal.
Like all boundaries are lost, and it's like that unlocking of potential for new thoughts, new ideas, and just like a new way of thinking. No, that's really fascinating. Maybe some sort of area of research area for the future, looking into different addictions or kind of dependencies in psychedelics. And so I'm just going to start by looking at the questions now. I just want to tell everyone they can fire away questions. But we've got a question here from the self-care doctor, and she says that one of the arguments against one of the arguments against comparative statistics is that millions drink alcohol but millions do not
take drugs.
It's really hard for me to. The millions do not take some illegal drugs. Unfortunately, the question's cut off.
Is she trying to sort of say that the numbers aren't comparative because so many more people drink?
I think that's what she's trying to say, but I think Instagram's only allowed quite a short question rather than a detailed explanation and then question. But let's go with that. So in terms of comparable data numbers and self-care doctor, if you're still with us, give us a thumbs up if that's the kind of gist you were going for.
A lot of people do actually take drugs. Recreational drug use is actually very high, but there are things you can, I'm not a statistician, but in David Nutt's analysis, that was accounted for, so you can correct for the numbers. So even though only sort of 20 people died from MDMA use over the past 10 years, even comparative to the number of people who take MDMA, that is still far less than the number of people that die from alcoholism. So these comparisons, it is corrected for how many people actually take the substance.
Brilliant. Yeah, she's given us a thumbs up, so I think that's the vibe she wanted. And lastly, just to wrap up, where do you see the future of psychedelic research in psychiatry, and as we've discussed today, in metabolic health as well, and lifestyle medicine, even outside of psychiatry? Where do you think it's going to take us?
Gosh, it's a good question. I think it would be amazing if we had something that really did work for depression. And so I just don't think, and I don't mean to, antidepressants, they work. For some people they work, and that is fantastic. But for a lot of people, they don't. They just don't. And they take these pills every day. And a lot of psychiatric medication have really high side effect burdens. I think, especially antipsychotics, they are.
I mean, you've
really
helped
bad.
us with that post this week, the effects of antipsychotics on metabolic health. It's astronomical.
It is, and I don't mean to kind of pill shame or anything like that. They really do help people, and that's great. But to have something that you can take once and really get to the heart of the problem, get to the core of what is actually going on. Because what I frequently see with antidepressant use is it helps people to carry on, but they carry on in the same negative situation. It gives them the energy to carry on, but actually it doesn't address why they're depressed. It doesn't address, often people are in really horrible situations, like they're doing something they don't want to be doing, or there's oppression or marginalization, or there's something about the situation that isn't right for them. And antidepressants just allow them to carry on in that situation. Whereas I think psychedelics, it allows people to suddenly look at the situation and see what's happening and say, actually, I don't want to live like this. I don't want to be in this situation. I want things to be different. And that's amazing. That's a cure. That's not just it's not just a sticking plaster. That would help people more, I think.
And in terms of the bi-directional relationship between the kind of psychedelic and the therapy from the actual psychotherapist, how do you think that actually works? Because obviously some people do really well from therapy, and I guess what we've discussed so far is that the actual psychedelic allows that readiness to absorb and receive the information from the therapist. So how do you think this relationship actually is in reality?
Yeah, so I think skipping back a bit, one of the problems with antidepressant use at the moment is they're supposed to be used alongside therapy. They're designed to be used alongside talking therapy, but because of NHS funding, that frequently doesn't happen.
Okay, that makes sense.
Really sad. Whereas psychedelics kind of put you into that ready, they make your neurons more plastic so you can make changes quicker. So the therapy courses can be shorter, which hopefully can be funded by the NHS. So I think there's something about the speed of change that psychedelics can cause alongside a therapist. Because traditional therapy it can take years. It takes years just to get past someone's defenses, to get them to open up and to be vulnerable.
The rawness, absolutely. And that's obviously the safety, like the psychedelic provides that safety, that it's not going to be so daunting. We've just had, and you're in that safe environment, like you say, you're not on your own, like in a forest, a festival, whatnot. So we've got a question from Manchester's Tank Society. With psychedelics, what sort of side effects would we have to manage? For example, would feelings of false sense of reality be one? Would we need to wean patients off after some time?
So with psychedelics, if we're talking about like classical psychedelics, so like magic mushrooms and LSD, during the actual trip, if you want to call it a trip, so for psilocybin, it normally lasts about 6 hours. With LSD, it's about 12 hours. During that period, it's expected that the patient will lose touch with reality. So they're quite high doses in these clinical studies. The patient will lose touch with reality, that they will go somewhere else, and it will feel like they're going into their own subconscious and exploring what's deep inside. It's very unusual for there to be any sort of lasting psychosis. That's one of the kind of myths of psychedelics. People think that you go mad and then that persists, but that's just not.
They never came back from that trip.
Yeah,
We've seen that in so much of pop culture and films and whatnot.
It's just not true. People do lose touch with reality whilst they are under the influence, but they wear off and people always come back. It's very rare to actually develop persisting psychosis. And then because it's not an addictive substance, there is no need to wean someone off. It's very unusual for people to take LSD or magic mushrooms consistently. It's just not really heard of.
Sure. I think we'll leave it there unless anyone else has burning questions, but just to say a huge thank you for taking part in this live. I've been so excited about it.
Oh, thank you for having me, Ali. It's really nice.
Yeah, absolutely. I think we've covered such brilliant ground, and you've just shown that the science is really there. It's just about all the other barriers in place and not to listen to the myths that are in the media. And of course, as you said, the media will talk about the most severe situation that's happened as a result of the drug, like that girl who passed away from her ecstasy in the club and whatnot. So honestly, thank you so much, Chloe.
Oh, thank you for having me. Thank you.
Can't wait to listen to Psychiatrics more.
Oh yeah, but a shout out to my YouTube channel.
Shout out about it.
Everyone subscribe to my YouTube channel, Psychiatrics. It's a
Very
modern
cool.
day psychiatry channel.
Some good life advice in there. Anyways, thanks so much and enjoy the rest of your evening.
Listen. Bye.
Bye.